coordinator, Dr. Mohandas Nair. Today's lead discussion, Dr. Prashant. Our senior faculty members, Dr. Parvati Madam, Purushottam sir, and also I am happy to see Murli sir after a long time, and Dr. Ladiga and all other friends, colleagues, and students. So it is one of the master program of IAP Kerala going very smoothly and also very enthusiastically. And happy to see that there are so many teachers attending the program and contributing generously. And also, I would like to congratulate Dr. Ladiga Nayar for the medicine coordinator and also Dr. Mohandas for organizing this program without any fail, means continuously without any interruption. And also, I wish the program all success. Jai Hind, Jai IAP. Over to Mohandas.
Dr. Prashant Pavitran,
Yes.
Vice President, IAP Kerala.
Yes, sir. Yes. Respected dignitaries, dear colleagues, seniors, Dr. Purushottam sir and Dr. Parvati. Today, best wishes of program which is conducted by IAP Thrissur and the PG Club program which has been going on very well every Thursdays and Thursday program. And today, Dr. Prashant Case is from SAT Trivandrum, who's fresh from State Conference of Pediatric Gastroenterology, the hybrid conference which we've done on August 4th. So he'll be the coordinator. He is the coordinator of the program, and also Dr. A.K. Andakeshwaran, Scientific Committee and Scientific Convener, Dr. Mohandas Nair, Dr. Ladiga Nair, who are doing a great work this year with this program. And also Amla Institute, today they are conducting Ria and case presentation from Amla Institute Thrissur. Best wishes to the program. Thank you everyone. JIP, Jai Hind. Okay, sir.
Okay. Now, Manjusha.
Thank you, Prashant sir, for that word. Now I invite Letika Madam, the coordinator for our zone, to introduce the mentor and the speaker.
Good evening,
Good evening, sir. Am I audible? Hello?
Yes.
Okay.
Yes.
Sir, am I audible?
Yes, you can wait.
Letika is audible.
Good evening, all. It's my pleasure to invite Dr. Prashant Case, Associate Professor, Division of Pediatric Gastroenterology, SAT Hospital, Trivandrum, as the lead discussant of the case. And the case is from Amla Institute of Medical Sciences, and the mentor is Dr. Ria Lucas, Associate Professor of Pediatrics, Amla Institute of Medical Sciences. And I invite Dr. Ria to introduce the presenter and the case.
Enable that one.
A warm welcome to all my seniors, my teachers, and my colleagues. Today, there has been some glitches in the presentation, but I think now everything is fine. Presenter is Ashley Sunny. She's our first year PG actually, and kudos to her to have the courage to present amidst all these style words. So let's hope that we'll have a nice learning session today, a very enlightening session from Prashant and from all the rest of my teachers. Thank you and welcome to you all. Ashley?
Ashley is, I think there is some problem in the network bandwidth. See, if she opens the video, I think it will be more difficult, I think. The network bandwidth is very low.
Okay, Ashley, you close your video and then just share the presentation. who's the one who's coordinating? Actually, she cannot share her screen. Can anyone enable that?
Mohandas sir, madam, ഞാൻ host അല്ല. Mohandas sir host ആണ്. Screen sharing
Screen share. അതാണോ പ്രശ്നം? Okay.
allow screen share കൊടുത്താൽ മതി sir.
I will do that. Yes. Now Ashley will be. Ashley, please share the screen.
Can you please try, Ashley?
So the case being presented is a 12-and-a-half-year-old girl who came with a fever of 2 weeks and rash of 3 weeks duration. So we'll see what the case is all about. Ashley,
റേഞ്ച് കുറവായിട്ടാണോ?
Bandwidth is unusually low.
ഇടയ്ക്ക് കട്ടായി പോയി സാർ. റീജോയിൻ ചെയ്യാം.
ആരെങ്കിലും അയച്ചു കൊടുക്കും. അയച്ചു കൊടുത്തിട്ട് നമ്മൾ കാണിക്കാം. ആ കുട്ടി പറഞ്ഞ നമുക്ക് സ്ലൈഡ് കാണിക്കാമല്ലോ.
വേറെ ആരുടെ കയ്യിൽ സ്ലൈഡ് ഉണ്ടോ?
മാഡം റിയ മാഡത്തിന്റെ കയ്യിൽ സ്ലൈഡ് ഉണ്ടാവും മാഡം? ഷെയർ ചെയ്യാം. Dr. Ashley, can you hear us?
Not audible, Riya. Ashley.
ആഷ്ലി ഒരു കാര്യം ചെയ്യാവോ? ആഷ്ലി ഈ ഇപ്പോഴത്തെ ഡിവൈസിൽ നിന്ന് ഓഡിയോ ഓഫ് ചെയ്തിട്ട് ഷെയർ ചെയ്യൂ. എന്നിട്ട് വേറൊരു ഫോണിലേറ്റം സൂം കയറി അതിന്റെ ഓഡിയോ മാത്രം എടുക്കും, ഹൗൾ ചെയ്യാണ്ടിരിക്കാനേ. അപ്പോ രണ്ടും വരും. ഇതിന്റെ ഇപ്പൊ ഓഡിയോന് ഇഷ്യൂ ഉണ്ടെങ്കിൽ ഇതിൽ ഷെയർ ചെയ്തോളൂ ഇപ്പൊ കാണുന്ന സ്ക്രീനിൽ. എന്നിട്ട് വേറൊരു ഫോണിൽ നിന്ന് സൂം കയറിയിട്ട് അതില് സംസാരിച്ചോളൂ.
ആഷ്ലി ഇപ്പം റീജോയിൻ ചെയ്തുകൊണ്ട് കോ-ഹോസ്റ്റ് ആക്കേണ്ടി വരും. നോക്കട്ടെ.
ശരി, ഈ ആഷ്ലിനെ കോ-ഹോസ്റ്റ് ആക്കിയാൽ മതിയായിരിക്കും സർ. അപ്പൊ ഷെയർ ചെയ്യാൻ പ്ലീസ് ജോയിൻ ഫ്രം അനദർ ഡിവൈസ്. യെസ്, ഇതിന്റെ ഓഡിയോ സ്വിച്ച് ഓഫ് ചെയ്യണേ. ഇപ്പോഴത്തെ വീഡിയോ കാണുന്ന ഡിവൈസിന്റെ ഓഡിയോ ഡിസേബിൾ ചെയ്തിടുക, ഹൗൾ ചെയ്യാണ്ടിരിക്കും.
Ashley, please share the slides now.
We can see your slides now. Can you please put it in full screen mode, please? Slideshow mode. Great. ഇതിന്റെ ഓഡിയോ ഒന്ന് ഡിസേബിൾ ഒന്ന് അൺമ്യൂട്ട് ചെയ്ത് നോക്കൂ. ഇപ്പൊ മ്യൂട്ട് ആയിട്ടാ ഇരിക്കുന്നേ. ഇല്ല, we can't hear you. I can't hear you. So disable this audio and join from another device. No. Under what name have you joined now? You have joined Zoom again, no?
Amal.
Yes, yes. So disable the audio of your video screen. Audio disable ചെയ്താൽ മതി. Mute അല്ല, മൊത്തം disable ചെയ്യുക audio.
Ma'am, am I audible from this?
You're audible, but there is a howling because there are two devices, no? The other,
If there are any
can you
other
share from this
devices,
device? Ash, can you share?
Slide share ചെയ്ത ഡിവൈസിൽ മ്യൂട്ട് ആക്കിക്കോ.
Mute ആക്കിയാൽ മതിയാവില്ല സർ, എന്നാലും
അതെ, അതെ.
ഹൗളി ആയിരിക്കും. ഡിസേബിൾ ചെയ്യണം,
Disable
ഓഡിയോ
ആവും.
ഡിസേബിൾ ചെയ്യണം. No, the present device, can you share? The one you are speaking, we are seeing you now. Can you share?
Ma'am, am I audible now?
You are audible.
Yes.
Can you share from this device?
Yes, ma'am. I can.
So please do
അല്ല,
that. Sir,
അതിന്
എന്നാ Ash എന്ന് പറയുന്ന
host
co-host
ആക്കേണ്ടി
ആണ്.
വരുന്നു. ഏത് ഡിവൈസിലാണ് ഇപ്പൊ ഉള്ളത്?
ASH, sir. Ash, ASH.
Okay.
Ma'am, is this okay?
Yeah,
Okay.
yeah. Can you share your screen now, the PPT? Are you able to share? Yes, the screen is being shared. റിയ മാഡം, മാഡത്തിന്റെ PPT ഉണ്ടെങ്കിൽ ഒന്ന് ഷെയർ ചെയ്യാവോ? അപ്പൊ പിന്നെ request the esteemed audience to please bear with us for a couple of minutes. We'll just sort this out fast.
No issues.
Thank you, sir.
മോഹൻദാസ് സർ, സാറിന് ഞാൻ PPT ഇപ്പൊ അയച്ചിട്ടുണ്ട്. സാറിന് അത് ഷെയർ ചെയ്യാൻ പറ്റുമോ അങ്ങനെയാണെങ്കിൽ?
ലതിക മാഡം, എനിക്കും കൂടി ഒന്ന് അയച്ചിടാവോ? ഞാൻ ട്രൈ.
മഞ്ജുഷ മെയിൽ ഐ ഡി പറയുമോ?
മാഡം വാട്സാപ്പിൽ കിട്ടിയിട്ടുണ്ട്. ഞാനൊന്ന് ലാപ്പിൽ തുറന്നു.
ലാപ്പിൽ അയക്കണോ? മെയിൽ ഐ ഡി
വേണ്ട എനിക്ക് കിട്ടിയിട്ടുണ്ട്. ഞാൻ
So the screen sharing is not on. Like it's disabled.
Manjusha, screen share. Co-host ആക്കിയിട്ടുണ്ടല്ലോ.
ഞാനല്ലായിരുന്നു സാർ. അത് ഞാൻ ജോയിൻ
ആരാ ഷെയർ ചെയ്യുന്നത്?
ജോയിൻ ചെയ്തു.
ഇതാണോ? ഓക്കെ.
ചെയ്യാനൊക്കെ ആഗ്രഹമില്ലേ? ചെയ്യുന്നില്ല.
Slideshow. So, can you see me? Can you see the screen?
Yes.
Can you hear the audio also?
The audio and video. Yes.
Good evening, everyone. Sorry for the delay.
Any other device switched on there?
No, sir.
Okay.
Good evening, all. I'm here to present a case of a 12-year, 6-month-old female child who was admitted from our OPD a couple of months back, and she was evaluated in our department. She was hailing from Thrissur, and the informant here is her mother, and the information is reliable. Moving on to her presenting complaints, she had rashes over bilateral lower limbs for 3 weeks, fever for 2 weeks, and throat pain for 1 week. And she had loose stools for 3 days, and blood in stools was noted for 2 days. Then moving on to the history of presenting illness, she had rashes. Initially, which was erythematous raised lesions of size 1 to 2 centimeter over the anterior aspect of both the lower limbs, which was associated with pain. Then gradually the swelling subsided, leaving behind a pigmentation. These lasted for a week and then disappeared. During the hospital stay, the existing lesions disappeared and new crops appeared. Then fever. Fever started 1 week after the onset of rash. High-grade fever with associated chills and rigor with diurnal variation, present more during the evening and night hours. The child had sore throat and oral ulcers for 1 week, which was associated with difficulty in swallowing food. Later, the child was noted to have loose stools for 3 days with nocturnal symptoms and with passing small volumes, semi-solid stools, 3 to 4 episodes per day with increased urgency and associated with blood and mucus noted for last 2 days, which is associated with pain in the perianal area while passing the stool. Moving on to the negative history, there was no history of vomiting, constipation.
Ashley, before going to the negative history, will you please try to analyze the symptoms.
Okay.
Starting from the, I presume that you have presented the symptoms in the chronological order, isn't it?
Yes, sir. Initially, there was rashes.
Please try to analyze.
The rashes were erythematous raised lesions. They could actually palpate the lesions. And it was associated, it was tender. The child complained of pain and they told the rashes subsided.
What was the distribution of these rashes? You mentioned like it is the lower limbs. Where exactly?
Sir, I'm not audible. Not clear.
I think a lot of background noise.
Yes.
I'll mute all. I'll mute all.
Okay.
Now, Dr. Prashant and Ashley, please unmute.
Yes. Ashley, you please unmute. Yes.
Yes, sir.
To try to analyze these symptoms one by one.
Okay, sir.
The basic idea will be to analyze the symptoms and try to figure out a few possibilities. And with that possibilities in our mind, let us go to the negative history.
Okay, sir. The rashes are resembling a nodule. So it could be erythema nodosum.
So where exactly, what is the, you have mentioned that the rashes were distributed in the anterior aspect. Where exactly? It's in the proximal part, distal part?
Sir, actually it was distributed in the thighs and also in the shin of tibia, sir.
Okay.
The child had lesions on both the sides. Actually, the picture that I have kept here is from her thighs.
Okay. You mean to say that the lesions were more on the thighs than to over the shin, isn't it?
It was both in both on like it was equally distributed.
Okay. Okay. Fine. How long did these lesions last?
Sir, it lasted for about a week, sir. Within 2 to 3 days, the raised lesions subsided and it became hyperpigmented, like pigmented patches, pigmented areas. Then it again, it resolved within a week.
Okay. 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 Fine. Okay. Fine.
So next. So can I continue?
Yes, please.
Okay.
So you have you are presuming that what is the lesion that you are attributing to, possibly?
Sir, with this description, it's possibly erythema nodosum, sir.
So what else could be the other differentials for such a rash?
It could be as there is a staining. It could be because of any vasculitic rash.
Yes. Anything else?
Vasculitic rash like HSP, and then It could be any viral exanthems, but
Okay.
nodular lesions are unlikely.
Okay. Anything else? Of course, you will be coming to, you may be coming into the negative history, but still, one more important thing you should tell at this point of time. Even the other postgraduates in the group can also answer. You must ask for some drug history also. Okay.
Okay, so like in negative history, I'm asking any drug.
Yeah, I mean, the symptom alone I'm telling, not the whole constellation of symptoms which you have alluded to. You have now 3-4 differentials for the lesions which you described.
Yes, sir.
Okay.
For like it could be any connective in any connective tissue disorders like sarcoidosis, inflammatory bowel disease, like chronic inflammatory disease like IBD. Then any infections. Yersinia can cause erythema nodosum like lesions. Then drug induced. Then
Okay, fine. Okay, let's move to the next one.
okay, sir. So next complaint, fever, sir. It started 1 week after the onset of rash, which was high-grade fever with chills and rigor. There was no diurnal variations. There was diurnal variation. It was present more during the evening and night hours.
So any pointer as to whether it is infective or inflammatory?
This could be infective.
What is the point under infection?
Sir, variation, it could be TB, tuberculosis, evening rise of temperature.
With just 2 symptoms, you can be sure that it is infection. Okay, these are possibilities. Don't.
It's a differential.
Yes, you have to present as a differential rather than telling as some abstract BDs. Okay.
Then the child, next symptom, the child had sore throat and oral ulcers for 1 week, which was associated with difficulty in swallowing food.
Okay.
It could be aphthous ulcers.
Where exactly is the distribution of the oral ulcers?
Sir, it was in the buccal mucosa initially, and while the child was admitted here, the child had lesions in the soft palate, sir.
Okay, so you mean to say that it was involved in the buccal mucosa as well as the pharynx?
Soft palate, yes.
Or pharynx. Okay.
Then the next symptom was the child was noted to have loose stools, sir. It was 3 to 4 episodes per day, small volume, semi-solid stools, and after the onset, the mother noticed blood and mucus in the last 2 days, and the child had pain in the perianal area while passing stools.
Please try to analyze the loose stools.
Sir, it's a small volume. Actually, there is a history that the child's sibling also had loose stool.
Concentrate on the symptoms. Those things we will bring in later. Try to analyze the symptom.
So the nocturnal the child was passing small volume semi-solid stools. It could be due to any large bowel pathology.
Okay.
It was mixed with blood and mucus, also suggestive of any large bowel pathology.
Blood and mucus. Ashley, what does this blood and mucus convey? Blood and mucus in stool convey?
Sir, it could be due to any inflammation.
Yes, it could be an inflammation. It is an inflammation. Some inflammation is going on. We are not sure whether it is an infection induced or a non-infective inflammation. Some inflammation is going on.
Yes.
Are you getting any idea regarding the site of involvement of the bowel? You mentioned that it is a large bowel. I agree. Where exactly in the large bowel it could be? In the proximal part or in the distal part? Because your accompanying symptoms are a pointer to the site
Sir,
of
in the
involvement.
distal part, sir.
Why?
The child is having pain in the perineal area while passing stools.
More than that,
Uh,
is having urgency.
Urgency also. Yeah.
Okay.
Then.
So before going to the negative history, what do you think the possible reasons could be if you want to explain all the symptoms?
Sir, it could be any inflammatory disorders like IBD.
How common are these disorders?
It's rare. It
Not
could be.
that rare, but still to discuss in an open-minded manner rather than confining to a particular. Can it be a simple viral infection or something?
Yes, sir.
Or
It
you
could
want
be
to
a.
attribute?
It could be an infection, sir. It could be an infection like HSP.
Okay, HSP. Okay, then
HUS. Any dysentery like
how many
salmonella.
how many cases of dysentery you have seen like presenting this way? What do you think the problem? Is it an acute process or something chronic is happening at this point of time? Given the short duration, given the spectrum of symptoms you have narrated, do you think that this is an acute problem or a chronic problem?
It's a chronic problem, sir.
Why? How can you say that this is a chronic problem? What is there in the history to suggest that? I mean, you will be given space at this point of time. Is it possible to tell that this is an acute problem or a chronic problem? Yes, you should be able to
The symptoms
substantiate.
have been started. It's been like 3 weeks, sir.
Oh, if you take the initial two symptoms, probably okay, but the subsequent symptoms have been there only for a few days.
Yes, so it could be an acute infection.
It could be an acute one or a subacute one. But are there any pointers at this juncture to tell that this is really a chronic issue?
No, sir.
No. So it should be very what they call very just with the symptoms.
Yes.
Okay. Please proceed.
Then there is no history of any vomiting or melena. No history of abdominal pain. No history of bulky or foul-smelling stools. No history of joint pain, swelling, or difficulty in movements. No history of dysuria. No history of rashes over the face or photosensitivity. No history of redness in the eyes. No history of headache, altered sensorium, or seizures. No history of having unpasteurized milk. No history of cough or breathing difficulty. No history of any nail changes. No history of any limb pain or no history of any recent travel.
What is the significance of which, you have narrated a whole list of negative history. What is the relevance of each point? Starting with the point number 1.
So vomiting, melena, suggestive of any upper GI symptoms.
What do you have in your mind when you are committing like this? There is no history of vomiting, no history of melena.
Any gastric ulcers.
Okay. Then
history of abdominal pain. It could be in HSP.
Yes, this could be one possibility. What else?
Then
the presentation fairly fits in with that of an HSP also. What else can cause abdominal pain?
Any surgical conditions?
Which surgical condition are you alluding to?
Any polyps?
Polyps.
Recurrent abdominal pain can be seen in gastric ulcers.
Okay. Would you like to qualify the abdominal pain a little bit further?
I couldn't get it.
No. What do you have in your mind when you have committed there is no history of abdominal pain? What are you trying to rule out? Or you should have some more specifics about the abdominal pain. Is it a localized pain? Is it generalized pain? The quality of the pain, your relation with the food, things like that.
Okay, sir. The child actually didn't have abdominal pain. If it is
Okay.
an
You want to say that child did not have abdominal pain? Okay. Okay.
and
The third one, no history of bulky or foul smelling stools. What do you have in your mind?
sir, any malabsorption?
Why all these things, bulky and foul smelling stools? What do you have in your mind? Why you want to bring malabsorption suddenly? This is like a no. For a given case, I think the negative history should be relevant to that case rather than a textbook narration of the whole lot of things that is narrated in the textbook. That should not be the way. Like it should be customized to the given case. What is there to tell about malabsorption at this point of time? You're getting my point.
Yes, sir.
Yes. Okay. The fourth one.
Some of the senior peers are also answering in between.
Yes, I was seeing somebody has mentioned about abdominal pain and intussusception. Do you feel that this is the age group for intussusception? Ashley? Somebody has mentioned that the abdominal pain could be related to intussusception. Do you feel that the entire presentation could be due to intussusception?
No, so it's unlikely.
What age group you typically get?
It's most commonly seen in the weaning age groups.
Okay. And usually follow some viral infection or something like that also. And in HSP also, intussusception is possible due to the enanthems, rarely. Okay.
No history of any.
Okay. What about history of joint pain, swelling, or difficulty in movement? What do you have in your mind?
Sir, it could be to rule out arthritis in HSP,
okay. So
IBD.
any form of rheumatologic involvement you mean?
Involvement, yes.
Yes. So it could be possibly a, HSP related or some other vasculitis related, or even what else can have joint involvement? Can inflammatory bowel disease have joint involvement?
Yes, sir. Extraintestinal manifestation,
Yes.
arthritis.
Or it could be even some. Okay, fine. Next one. No history of dysuria. What do you mean? What do you have in your mind?
To rule out any UTI, like in IBD, there could be possibility of cystic fistula.
Very, very. Okay.
Very
no history of rashes.
Rashes or photosensitive.
So what are you trying to rule out?
Sir, SLEs.
Okay, vasculitis. Is it possible for a child of this age?
No, sir.
No, why? Why not?
No, 12-year-old, yes.
12-year-old, and what about the gender?
A female child.
It's very much possible.
It's possible.
So you must keep all the options open rather than trying to keep the door closed. To leave more space for discussion. No history of redness in the eyes. What are you interested about?
Sir, any uveitis. It can be an extraintestinal manifestation.
Okay.
In IBD.
Right. Next one. No history. No history of headache, altered sensorium, or seizure. What are you trying to rule out?
Sir, in CNS involvement could be seen in like vascular diseases like Behçet's disease, vasculitis.
Questions, does it involve the CNS?
Yes, sir. SLE, it could be in SLE.
SLE, okay, okay, fine. What do you have in your mind when you are telling that there is no history of having unpasteurized milk?
Sir, in abdominal TB, this could be a possibility. Unpasteurized Mycobacterium
You
bovis.
are considering only the possibility of MTB infection alone, or any other infections are possible with this kind of a presentation?
Brucellosis.
Brucellosis. Anything else?
Campylobacter.
Campylobacter. Okay. Then next one, no history of proper breathing difficulty. What do you have in your mind?
Sir, as the child had erythema nodosum and features, it could be sarcoidosis also connected to.
Sarcoidosis. Okay. Anything else? Common ones?
In T.
Tuberculosis. Okay.
TB, tuberculosis.
So what sort of nail changes you are interested in?
Sir, sorry?
What sort of nail changes you are interested in? Nail changes. Nail changes. You are mentioning.
Nail changes. Okay, nail changes. Like any polyonychia, iron deficiency,
Okay.
or any signs of chronic, like any vitamin deficiency. Yes.
What vitamin deficiency?
Hypoalbumin, iron deficiency, then hypoalbuminemia.
Other than the pigmentation, what else you will be looking into?
Clubbing, sir.
Yes.
Chronicity.
Even though it forms a part of the examination, but still, since you have mentioned nail changes, I was interested in knowing what sort of changes you will look into ideally. No history of limb pain.
So, like bond pain, any to rule out any malignancy.
Yes, malignancies. Okay, malignancies can also present like this. History of recent travel.
Sir, travel to any endemic areas for infections.
Like?
Infections like tuberculosis. Travel history.
Okay. Let us move forward.
Travel could be salmonella also.
Okay.
Malaria. Then treatment history. Can I move on to treatment?
Yes, you proceed.
The child was treated with capsule amoxicillin 250 mg TID for 5 days for the fever, and symptomatic management with oral gargle was given. Oral gargle and ointments were given for oral ulcers.
Okay. So these were the only drugs that were given in the initial phase.
Yes, sir.
Okay.
Then past history. The child had history of grommet insertion in ear at 4 years of age for OME. And the child was noted to have decreased appetite with early satiety for the past 2 years. Parents also noted poor weight gain for the past 1 year, but they do not have any records available, sir.
Okay.
Also, the child did not have any history of altered bowel habits, or no history of any recurrent respiratory or gastrointestinal tract infection, no history of any chronic drug intake.
So what do you have in your mind when you are telling like the child was noted to have decreased appetite with early satiety for 2 years? What do you want to convey?
So for 2 years, it's a chronic illness.
Okay. What sort of chronic illness? Why the child is having decreased appetite and early satiety?
It could be due to like at this point, I could think of IBD, like inflammatory.
What is the reason for why why a child will have a early satiety and all? Decreased appetite could be a manifestation of the ongoing inflammation. So there will be generally anorexia. Early satiety may be due to the possibly some upper GI involvement. Okay. The parents have noticed that there is decreased weight gain for the past 1 year. So some amount of chronicity is there actually when you go back to the past history, isn't it?
Yes.
Yes.
Yes,
So,
sir.
no history of altered bowel habits. What sort of bowel habits you are interested in? What history will you specifically ask?
Sir, altered like past history of chronic diarrhea and
Okay.
constipation.
Okay. So in what way that history can help in reaching a etiological diagnosis?
Sir, altered bowel habits.
Altered bowel habits can be loose stools, blood in stools, painful defecation, or constipation, whatever it is.
Oh.
So, what are the possibilities that are possible if there were some altered bowel habits? What are the possibilities?
It could be irritable bowel syndrome.
Irritable bowel syndrome. Irritable bowel syndrome, will they present with the weight loss and all?
Sir.
With the lack of weight gain and all?
No, it could be inflammatory bowel disease.
It
Could be my first
inflammatory or infective.
Infective.
Suppose there was a history of constipation and in between you are getting blood in stool. What else you do? What are you trying to point out? Have you heard about a condition called solitary rectal ulcer syndrome, SRUS? That could be seen in chronic constipation also. They can also present with the bleeding PR occasionally. Okay. What are you trying to rule out by telling no history of any recurrent respiratory or GI tract infections?
Sir, immunodeficiencies.
So what sort of immunodeficiencies you have in your mind?
Sir, immunodeficiencies, sir. CGS, sir.
CGD.
CGD, sir. CGD.
How do they classically present? What sort of involvement it is?
With pneumonia, sir.
Pneumonia and usually cutaneous involvement and all. Which is the immunodeficiency that presents with the GI manifestations. And this child has been thriving well for last 12 years without any major admissions for any significant unusual infections. When do you really consider immunodeficiency as a possibility?
If it was early
onset, unusual sites of infections, refractory infections, those are the settings where probably you may consider the possibility of immune deficiency. Okay.
Yes.
Now, history of any chronic drug intake. What are you interested in?
Sir, any chronic antibiotic intake?
Chronic antibiotic intake for what?
Not chronic antibiotic, long duration of antibiotic intake to rule out pseudomembranous colitis.
Okay. You are considering that possibility also. Okay. Please proceed.
Antenatal history. She was the second child of a non-consanguineous marriage. Maternal age at conception was 28 years. She was a booked and immunized case. Regular antenatal checkup were done. No history of fever with rashes or radiation exposure. No history of any comorbidities in mother. All the antenatal scans were initially normal, but growth scan showed fetal growth retardation in the last trimester. Next.
Yes.
Natal history, the gestational age was 38 weeks. It was a normal vaginal delivery with birth weight of 1.95, low birth weight. Then baby cried soon after the birth, sir.
Okay.
Then the postnatal history, the baby was shifted to NICU for low birth weight care, and all the postnatal, the postnatal period was uneventful, sir. And the baby was discharged on postnatal day 4 from ICU.
Okay.
Moving on to the developmental history. All the developmental milestones attained appropriate for the age. She has good scholastic performance. She's currently doing her 7th standard. She's active in sports in school. Also, I would like to add the personal history here. The child attained menarche at 12 years, 12 year, 2 months of age, and did not have any further menstruation for the last 4 months. Shall I proceed?
Yes, proceed.
Diet history. The child was exclusively breastfed till 6 months of age. Child did not have any intolerance to any particular food or milk. The child had intake of spicy and fried food items on a daily basis. And the child had frequent intake of processed foods.
What is your idea of asking all those details in particular? Like a child did not have intolerance to any particular food, well, intake of spicy fried food items on a daily basis, intake of processed food. What do you want to rule out?
Sir, intake of spicy and fried food items in case of peptic ulcer.
Because, sir, are you considering here it as a possibility?
No.
The consumption of these ultra processed foods, etc., are linked to the development of IBD. So that way it may be relevant. You mentioned that the child had frequent intake of processed and ultra processed foods.
Yes.
Okay. Next one.
A lack of fiber intake.
Yes.
So the detailed diet history was taken, and it was found to have, the child was found to have a deficit of 700 kilocalories and protein deficiency of 3 grams.
This was the decreased appetite. Is it a volitional restriction or involuntary restriction? Involuntary.
It was involuntary restrictions.
Involuntary. Okay.
Then immunization history. The child is immunized up to age according to national immunization schedule. A BCG scar is present. No adverse events following the vaccination.
What are you trying to convey by telling that the BCG scar is present?
Immunodeficiency.
What sort of immunodeficiency you are trying to dispel? Okay, please. Proceed.
So family history. There is history of ITP in one of her siblings. It was treated 1 year back with IVIG and no further symptoms. And there is a history of query IBD arthritis in her maternal aunt, but they do not have any records available as she was in, treated abroad. No history of any loose stools. There was a history of loose stools in one of her siblings, following which the child developed the symptoms. There was a history of CA stomach in her paternal grandfather. There is no history of contact with TB.
Does the family help you in any way?
Sir?
Does the family history help you in any way to reach the differential diagnosis, to narrow down the differential diagnosis?
Yes, sir.
How does it help? How does the family history, what specifics in the family history do help you to narrow down to the differential diagnosis? Is the relevance of family history of IBD and etc.
Yes, sir. The maternal, the second degree relative is having a history of IBD.
So if you have a family member there, family history there, you have a 20 to 30% likelihood of the child also getting diagnosed as IBD.
Yes.
Okay.
Then moving on to the socioeconomic status, she belongs to an upper middle class family according to modified Kupaswamy scale. Her father is an IT professional and her mother is a homemaker. Then summary. A 12-year, 6-month-old, developmentally normal, fully immunized child. Second, child of non-consanguineous marriage with family history of IBD, query IBD, having decreased appetite for the past 2 years and poor weight gain noted for the past 1 year, now presented with edematous raised lesion in the anterior aspect of lower limb for the past 3 weeks and high-grade fever for past 2 weeks with blood-stained loose stools for past 2 days with poor dietary intake.
So you have now reoriented the symptoms to include the past history as well. And you have placed it on top of that and tried to connect with the present symptoms, isn't it?
Yes.
Okay. So what are the possibilities you would like to consider after taking the history? The list of differentials that you would like to entertain?
Sir, as this is a chronic illness, the child is having history for 2 years. So I would like to consider chronic disease like IBD as my provisional diagnosis.
So again, the list of differentials should not be okay. IBD. Other possibilities?
Other possibilities are HSP.
HSP going on like this for 2 years.
No, sir. It could be.
So I think
acute presentation.
If you are given an opportunity to rearrange the possibilities, which one will you bring up?
Abdominal.
We have narrated a whole lot of differentials, other possibilities. Among the other possibilities, which one would you like to place up?
Chronic lesions like Behçet's disease.
Behçet's and all, how common? What is there to suggest in the historically? How does Behçet's disease typically present?
Then abdominal tuberculosis. Abdominal TB, sir.
Abdominal tuberculosis. Okay. But again, I would like to tell that there is not much of a luminal symptom. Whatever is there is only predominantly the systemic symptoms in terms of anorexia, weight loss, and whatever luminal symptoms the child is having, it is very short duration. So you should be very, very careful when you try to fix it up. If there was some chronic history like alternate bowels, etc., then probably yes. Why you want to bring in celiac disease? How do they present, typically present?
Celiac disease, like initial
what is the typical presentation and what is the atypical presentation? What is the typical presentation? When do you get?
Sir, gluten sensitivity, sir, insensitivity. It's mostly during the initial infancy period, sir.
Okay. Then they will during that time they will present mostly with the luminal symptoms like diarrhea, etc.
Diarrhea,
but do they present with inflammatory diarrhea or they present with watery diarrhea?
Watery diarrhea.
Present with the blood in stool or without blood in stools?
Blood.
No. Isn't it never does not present with the blood in stool and all celiac disease? Okay. And what about the atypical presentation like? How can they present in an atypical way? That is, even without luminal symptoms, this celiac disease can present. How do they present? Are there anything in the history to suggest that this could be celiac disease? Any particular symptom?
Sir, failure to thrive and severe anemia.
Failure to thrive.
Failure to thrive. What is there in the failure to thrive? The only point is like the child is failing to gain weight, but more than the gain in weight, something else. They can present with the stunting. They can present with anemia. So those are the pointers. They can present with a delayed puberty. Anything like that?
The child is having like did not get the menstruation following menarche.
That is nothing unusual in that. Okay, what about the other possibilities? Sarcoidosis and all. Sarcoidosis is very rare. And what malignancy would you like to consider at this age?
Sir, any lymphoma?
Lymphoma. That's also quite unusual. I think drugs also you should consider the possibility of intake of some drugs. Okay. So still you would like to give a weightage to inflammatory bowel disease because you are skewed by the family history.
Yes.
I'd like to keep the possibility of IBD upfront. Okay. So now you have listed down the differentials. So with these differentials in the mind, we will try to do a very focused examination. Okay, proceed to the examination part.
So on general examination, the child is alert and cooperative. The child is thin built. Pallor was present. Erythema nodosum, the tender subcutaneous nodule of size 1 to 2 centimeter was present over the anterior aspect of bilateral thighs during the examination. Left jugulodigastric nodes were palpable. No other lymph nodes were palpable. No icterus or cyanosis or clubbing or pedal edema. All the vitals were stable.
Please go back. Please go back. How can you say that vitals are stable?
Oh, sorry. The pulse rate was 120 per minute.
What could be the reason for that?
Fever, sir. The child had fever.
Fever. Anything
Fever.
else?
Right.
Anemia.
Anemia.
Anemia. Okay. Okay, proceed.
Anthropometry. The weight of the child was between 3rd and 10th centile according to IUP chart, growth chart. Height of the child was between 25th and 50th centile. The BMI was calculated and it was found to be 13.4, which was on the 3rd centile. SMR staging was done and she belonged to stage 3.
Okay, what is the interpretation?
So there is
interpretation of the growth centiles.
So there is severe undernutrition.
Undernutrition. Okay. Why you say that there is severe undernutrition?
The weight of the child is between 3rd and 9th centile, 10th centile, and the BMI is on the 3rd centile. So there is growth retard.
But there is not much of stunting.
No, not much of stunting.
And even the pubertal staging is also fairly okay.
Yes.
Okay. Okay. Then.
So this is a growth chart plotted. Then moving on to head to foot examination. Shape of the head was normal. There was no features of any alopecia.
Why you are specifically mentioning about alopecia?
SLE, sir.
Lupus. Okay.
The eyes was normal. No features of.
Can you explain this case in particular? What are the things that you will specifically look for in the eyes?
Uveitis, features of anterior uveitis, sir.
Okay.
Redness.
Then.
Episclera, redness. Then.
These are the only. These are the only points you will look into.
Then pallor.
Yes, pallor. One is the stigmata of the etiological process that you consider. The other thing is the fallout of the etiological process, like anemia, things like that.
Then there are no rashes in the face. BCG scar was present. No nail changes. No clubbing or koilonychia. Then no joint swelling or tenderness. No signs of any vitamin deficiency.
Okay.
Shall I
proceed,
sir?
Proceed.
Then examination of GIT, upper GIT. Lips does not show any pigmentation. Then gums appeared normal. Then teeth are prominent, good oral hygiene with no dental caries. Tongue did not show any thrush or desquamation. Oral mucosa, multiple aphthous ulcers were present superficially over the soft palate and the buccal mucosa. Tonsils not hypertrophied or inflamed. Pharynx were normal. Pharynx looks normal.
Okay. So what sort of changes you will look in the lips and gums specifically?
Lips hyperpigmentation in Peutz-Jeghers syndrome.
Okay.
Then after ulcers.
After ulcers. Then as part of micronutrient deficiency, will you look for any changes?
Angular stomatitis.
Angular
in
stomatitis, cheilitis, and all those things.
Cheilitis.
Okay. Okay. So the only positive thing is the after ulcers, which are present in the palate and buccal mucosa.
Palate and the buccal mucosa.
Okay.
On inspection, the shape of abdomen scaphoid, skin of the abdomen normal with no scars or sinuses, flanks was normal, umbilicus normal in position and appearance, all the 4 quadrants moves equally with respiration, hernial orifices normal. No positive find.
Okay.
And on palpation, abdomen was soft, non-tender, no warmth or guarding or rigidity, no organomegaly, no palpable mass was felt.
Okay.
On percussion, no fluid thrill or shifting dullness or puddle sign was seen. On auscultation, bowel sounds were heard. And external genitalia, no genital ulcers was seen.
So you are trying to rule out. You are trying to rule out which differential?
Base sheets.
Base sheets. Okay.
Then anus and rectum, skin tag was present. Anal fissure was noted, and no perianal excoriation or perianal fistulas.
Does these findings give any added inputs for your etiology?
Yes, sir. As my primary diagnosis was IBD, this perianal findings suggestive of Crohn's disease.
Okay. Okay.
Then other systems were within normal limits. Shall I proceed?
Yes.
Summary. 12-year, 6-month-old female child admitted with family history of query IBD, having a decreased appetite for the past 2 years and poor weight gain noted for past 1 year, now presented with erythematous nodules in the anterior surface of the lower limb for past 3 weeks, high-grade fever for past 2 weeks, with blood-stained loose stools for past 2 days, with an inadequate nutrition. The child, on examination, the child is emaciated with pallor and erythema nodosum in the anterior surface of the lower limbs, with weight below 10th centile and BMI on the 3rd centile. On examination, oral mucosa showed multiple aphthous ulcers over the soft palate and buccal mucosa with a skin tag and anal fissure on perrectal examination.
Okay.
So here, differential diagnosis.
Why this typhoid, celiac, etc.?
Typhoid can also present, like the past history does not support a typhoid, but the current presentation.
So you mean to say that child is having something else, on top of that, child is also having typhoid also?
Could be a possibility.
Why immunodeficiency?
Immunodeficiency.
Okay.
As the child.
Okay. So how are you going to work up the child? I think we have around 15 more minutes, I think.
So we have done the.
1 second. Ria?
Prashant.
How much more time we have? 15 minutes?
Yes, we can go for 15 minutes. But you want to complete.
Okay. Okay.
Sir, investigations, we have investigated the child.
No. Before you go to the investigations, you close the. How are you planning to work up the child?
Routine blood investigations were done to be done, sir.
Why do you want to do the routine blood investigations? What do you have in your? What is the purpose of doing? For any investigation, you have a purpose. You foresee something and then you order the investigation. So what do you have in your mind when you order the routine blood investigation? It is not like a customarily mentioning that these investigations.
Yes, sir. As I'm suspecting inflammation, I would like to
So
look
you
for
are
the
all infective pathologies you have omitted, other than the TB, typhoid. Even though you have mentioned earlier during the course of discussion, you had mentioned lot of infective pathologies. You are discarding all those possibilities in the differential diagnosis. You mentioned about Campylobacter. You mentioned about Yersinia. You don't want to entertain those DDs.
as it's the chronic pathology.
Okay. Please proceed with the investigation.
Shall I?
You can show the investigations.
Investigations. Hemogram was done, showed normal counts with elevated inflammatory markers.
No,
Yes,
with the no, not even anemia was not there.
yes, sir. Low
How much
hemoglobin.
was the hemoglobin?
HB was around 8, sir. We have given a PRBC transfusion notes.
Hemoglobin was 8, and you have transfused there.
Yes, sir.
What was the indication?
Before the onset of before starting the biologicals.
Biologicals. We have not reached the diagnosis. Okay.
Then peripheral smear done showed microcytic hypochromic anemia with which is
does the symbol hemogram and peripheral smear give any idea regarding an etiological possibility?
yes, sir. Anemia suggestive of any
anemia suggestive of
chronic malabsorption.
It could be chronic malabsorption, or it could be chronic malabsorption, or it could be part of some chronic inflammation. Both way it is relevant. My point is, are the investigation findings in the peripheral smear and hemogram help you in any way in reaching the etiological diagnosis? If everything is put together, hemoglobin, the WBC count, the platelet count.
Yes, sir. It is suggestive of inflammatory bowel disease.
You get elevated platelets also. So that is a suggestion that it could be an inflammatory bowel disease. What is adding more credibility to the hemogram findings? You have checked the inflammatory markers. They are also elevated.
Elevated.
Okay.
Blood culture.
You have examined the stool?
Yes, sir. Fecal.
Microscopy was done?
Yes, sir. Stool protein was done and was
Microscopy was done?
Yes, sir. No. So no features of any ova or cyst.
Okay.
Then fecal calprotectin was done.
Why fecal calprotectin was done?
It is highly sensitive and specific marker for intestinal inflammation, sir.
We just tell that it is intestinal inflammation. It does not convey any etiological diagnosis. You just want to be sure that you want to have an organic pathology. You want to rule out an organic pathology. But in the setting of a frank inflammatory diarrhea, this may not be an ideal proposition, because blood in stools, that can also falsely elevate calprotectin. Okay. Anyway, you got a very high calprotectin. Do you have something before you contemplate something? You do the calprotectin. So how do you proceed further? How do you want to convey? Anything else you want to rule out? Because tuberculosis was one of your differential diagnosis. IGRA also you have done.
Culture.
Okay. IGRA is also done. IGRA is also negative.
Is also done negative.
Okay. X-ray chest.
X-ray chest was done, sir. It was also these are the positive findings. X-ray chest and was done. Did not show any features of.
We have a high index. So you have a high index of suspicion with the baseline investigation. If you are given one more investigation, one more baseline investigation, what will be the one that you will opt for? Along with anemia, thrombocytosis, elevated CRP, elevated ESR, if you are provided the option of choosing one more additional investigation, what will you choose? Albumin, serum albumin.
Oh,
hypoalbuminemia. Okay.
So USG abdomen was done. It showed diffuse thickening and edema of the descending and sigmoid colon with increased vascular signals, thickening of adjacent fat tissue, and few small lymph nodes, suggestive of infective or inflammatory etiology,
So
and
your,
mildly
your clinical correlation of your clinical assumption of involvement of the left side of the colon is being validated by the imaging findings.
Yes.
You mentioned your clinical assumption of involvement of the left part of the large bowel. That is being
Yes.
validated by the imaging, isn't it?
image. Yes, sir. Then mildly edematous small bowel loops at the umbilical and right lumbar region.
What does that point to?
Sir, it could be a Crohn's disease, small bowel involvement.
So you mean to say that there is only a small bowel involvement, or large bowel involvement is also there based on the history examination?
There is both large bowel and small bowel
Both
involvement.
large and small bowel. Okay. How do you want to
Then-
proceed further? You have images of the colonoscopy and colonoscopy, etc.
Oh no, sir.
No, you have not added. Okay. You have done. You have done colonoscopy.
Yes, sir. Colonoscopy was done and it was found to have deep longitudinal ulcers with erythema in the rectum, rectosigmoid and sigmoid and descending colon.
Have
MR
they,
intro.
have they gone into the terminal ileum also?
Sir, sorry.
Have they gone into the terminal part of the ileum also during colonoscopy?
No, sir. They have done.
It is not a complete assessment. It should have gone to the terminal part of ileum.
And in that small bowel involvement was confirmed.
Segmental involvement is really involvement because if you want to classify the type of involvement, whether it is a ileum plus colon or colon alone or ileum involvement alone. So a complete colonoscopy would entail intubation into the terminal part of ileum also.
Then biopsy was done from sigmoid colon and rectum.
What about the right part of the colon, especially ileum, cecum? I mean cecum and all. Any involvement there?
Yes, sir.
We did not mention anything. Clinically also we did not expect anything because there is no pain in the right iliac fossa or things like that. During the examination also no
Pain
finding.
not tender.
Okay. Okay. Do you feel that your investigations are complete?
Sir, involve like blood investigations, other workups.
No, blood investigations you have mentioned that. I think with regard to endoscopic evaluation, I think endoscopic evaluation in a suspected case of Crohn's will not be complete.
We have to do OGD-scopy also.
Upper GI involvement also. Because
Yes.
why? Why?
In Crohn's disease, like it can involve in any part of
the upper GI as also in 20 to 30% of the cases, and we are not sure from which area you are going to get the typical granuloma, etc. Sometimes the yield of granuloma, etc., are very, very dismal. It is seen only in 1/3 of cases. That too with the best of the histopathologists. In this case, you are lucky that you could you could get the granuloma.
Yes.
Can you mention some more details? Okay, fine.
Shall I? OGD-scopy was not done for this patient, sir.
It was done.
Not done, sir.
Okay. I think OGD-scopy is also required, and also small bowel evaluation is also required. Small bowel evaluation imaging. Imaging can be either CT angiography or MR angiography. But clinically there is suggestion. But clinically there is suggestion of small bowel involvement also. Priya?
Yes, Prashant.
Can we stop here and can we ask for inputs of the senior teachers?
Yes, definitely. Dr. Latika, Dr. Mohandas, sir.
I think we have discussed everything well. Are there any questions in the chat box, Elsie?
No, that before that, any comments by the senior teachers?
Can you stop screen sharing so that everyone can see each other? പുരുഷോത്തമ സാർക്ക് പോയി തോന്നുന്നു അല്ലേ? ശ്രീനിവാസൻ സാർ ഉണ്ടോ?
Many have left, I think, sir.
Geeta, any comments?
Really an interesting case, Priya. Ashley has presented very well, and it's an interesting case. Inflammatory bowel disease, it's not that common in our place, no?
No, madam, it is quite common from the northern part.
Yes.
We are also seeing more and more cases, madam. Unlike the previous days, we have started seeing more cases.
One of my relatives had IBD. She had lost nearly 10 kilos during
People taking food
period of 2
outside,
years.
all junk foods.
During a period of
There's a
2 years.
possibility of more cases of such
Yes, yes.
chronic inflammatory bowel disease.
With the intake of more and more of ultra processed food and the rampant and indiscriminate use of antibiotics quite early in the life, and lack of exclusive breastfeeding.
So, with any documented weight of this girl before?
2 years. Since 2 years, she is not taking much food and lost weight also.
Actually, the parents say that there is weight loss. They noted the weight loss, but they haven't. No records are available. We couldn't get the immunization card, and it's not entered actually. At 10 years and all, it's not recorded.
So her height is almost normal, but she's significantly wasted.
So that is also a different kind of presentation. We are not seeing the classical type of presentation. We may see obese children coming with weight loss. They are also having IBD. So every time it need not be like emaciated appearance alone. The index of suspicion has to be very high. Sometimes they present even with the extraintestinal manifestation upfront rather than the luminal symptoms. But in this case, I think even though weightage was given to the extraintestinal manifestation, but everything put together, it was correlating with the background history of anorexia and the lack of weight gain over the past 2 years.
So Prashant, if you would just say the red flags, like when we should suspect IBD or some.
Yes. One is like chronic abdominal pain is such a common thing, and our endeavor should be to find out the red flags. The red flags include, as she pointed out, like failure to thrive. That means lack of weight. That is inability to gain weight, height, etc. Presence of anemia, then presence of this perineal lesions in the examination, like skin tag, fistula, non-healing, ulcers, etc. And all these could be pointers. The presence of extraintestinal manifestations like erythema nodosum, joint symptoms, ocular involvement like uveitis, etc. All these are pointers that probably we could be dealing with inflammatory bowel disease or any organic pathology for that matter. Tuberculosis will also come into that basket. Vasculitis and other entities are quite uncommon, even though we traditionally describe. But the other chronic infections also should also be brought under the ambit of discussion. Why there is no pain and also high fever? The high fever could be part of the inflammatory activity, because there is lot of inflammatory mediators involved. So that could be the reason for the fever. And abdominal pain, that child will develop in due course. This probably we have picked up early. Most of the time when we diagnose IBD, it would have had a natural history of 4 to 5 years. If somebody is having a sequential follow-up only, then we can be easy for them. So they will have gone from one doctor to the other. By the time they have reached, they would have passed a natural history of 2 to 3 years. So classically, abdominal pain should be there, but in this case, there is not that history. But that doesn't mean that we should not suspect, because everything put together, there is a valid ground for suspecting IBD. Suppose you have stopped investigating and not worked up, you would not have picked up either.
What is the general response to treatment and how you?
That depends upon the pattern of involvement and the severity of involvement. First of all, you have to decide on the severity. Severity, there are some tools like for Crohn's disease, there is an index called CDI. There is a pediatric variation for that also. Based on the, these are very easily, these can be very easily calculated. Nowadays, we have the QX calculator app and all, so many things are there. There are a whole lot of symptoms and a whole lot of investigation findings. You respond to those symptoms as well as enter the investigation variables, and you will get a numerical value. Based on that, you stratify it into mild, moderate, and severe. So if it is a severe one, then probably we'll have to hit hard. And depending upon the pattern of involvement, suppose there is a perianal lesion, etc., then probably the biologicals would be the upfront factor. Other than if it's a mild to moderate, then you start with the steroids for inducing remission, and you maintain it with some immunomodulator like azathioprine or 6-mercaptopurine and things like that.
Any other comments or any doubts?
Actually, how does the fast foods increase the incidence of IBD?
Everything is related to gut dysbiosis, madam. It is said to alter the normal flora that in turn affects the gut, the local immunity in the gut, and that leads to unrestrained inflammation, all those things. Yes, sir. Muralidharan sir has asked a question. Erythema nodosum as the first. It is not common, but it is not unusual also. Many a times you can have extraintestinal manifestation as a forerunner of the classical luminal symptoms in the case of IB.
Okay. Thank you.
Here probably the disease started 1 or 2 years before, isn't it?
Yes. Because Mohandas sir was asking the baseline weight. If somebody was very closely following it up in a longitudinal manner, then probably this lack of weight gain or drop in the centiles would have given a better clue for the evaluating physician. Nowadays, what we see are these kind of atypical presentation rather than the classical presentation when they present with the chronic diarrhea and all. Most of them present with prolonged periods of growth failure, anemia. Then very later only they tend to have all the classical luminal symptoms. And these symptoms do not have a correlation with the endoscopic severity also, vice versa also.
If that past history is not taken properly, probably the diagnosis may be enteric fever or
yes,
tuberculosis of abdomen or something like that, isn't it?
Yes.
What's the prognosis, Dr. Prashant?
Early treatments they have a better quality of life. If we tend to delay the treatment, they are likely to go in for complications like strictures, fistula, etc. And all. This is for with regard to Crohn's disease. But between Crohn's and UC, I would say that ulcerative colitis behaves very badly in children. It is mostly pancolonic involvement, and almost many of them present with severe disease, unlike in adults. But in Kerala, we see more of Crohn's in comparison to ulcerative colitis. And nowadays, even the younger children are also getting. That is adding to another basket. So that is thought to have, especially children less than 6 years and or children less than 2 years, they are said to have a genetic basis for IBD. So they do not respond to the classical medicines like steroids, azathioprine, and biologicals. And many of them are having an underlying immunological basis also.
What about marriage later?
They are possible, madam. They are having it. The treatment should be done very judiciously. That's all. Delaying the treatment is not going to help them either, in terms of the disease trajectory and also about the complications. And this child has a long way to go.
So, but can we stop treatment at some point of time, or is it a continuous process?
Stopping the treatment will depend upon, for a Crohn's disease, I think nowadays what we are aiming is deep healing. It has to be cross-sectional imaging has to be done, and we have to be sure that the mere presence of settling of the inflammatory markers like ESR, CRP won't be sufficient to stop the treatment. We have to aim for cross-sectional healing. Even when we do scopy, we are able to see the inside only, but still inflammation may be going on. So ideally what we do is we repeat the imaging, etc., probably after 1 year, etc., to decide upon the continuation of treatment. And cost is also a limiting factor in our settings, because biologicals are very expensive. Biologicals, again, there is no general treatment for all cases, and it has to be highly customized depending upon the phenotype, severity, etc.
There are no further queries. Can we wind up?
Yes.
Yes. Yes, sir. I think all the pages have left now. Okay. So thank you. Thank you, Dr. Prashant.
Thank you, Ria, for the opportunity. I hope it was of some benefit.
Definitely, definitely.
It is very useful.
Anyway, I must appreciate Dr. Ashley for her courage to discuss a unusual case. Normally, the residents are. She is not. I think she
is a first year PG also.
I must appreciate her for her boldness to take up a case.
So I can pardon her mistakes.
Yes,
she has done.
It's only a learning exercise, but she had the courage to take it. She needs appreciation.
It's also gone through the lot of trouble in the initial period. Yes.
Yeah, in spite of all that. Okay. Sorry for all the glitches, sir. I think next time we'll.
Then somehow we could.
Yeah, in the department and the.
It happens. No.
Thank you, sir.
Okay. Good night.
Ashley, best wishes.
Thank you, sir. Thank you so much. This is a really good discussion, sir. Thank you.